going to use active and live. Yeah. Good morning, everyone. It is Wednesday, March 18th, and this is the Senate Health and Welfare Committee meeting. And we're taking some time over the next few days and weeks looking at the bills that have come to us from the House. We're also going to pick up some special topics going along. Prevention, for one, that we talked about yesterday a little bit. So, but this morning we're starting out with H84. It's an act relating to allowing telehealth appointments to be recorded with patient and provider consent. I know it's a bill that's important to us. We have one in here, and the House has worked on it. So, you are the reporter, and are you the sponsor in the House as well, Representative Rebecca?
I am a co-sponsor.
Okay. Come on up to the chair.
I was hoping Jen was going to come there. 84 was quite a while ago. We're in the
It's okay.
now.
You know, our goal here is just to get the overview and the why the bill was introduced and start kind of that general significant importance. And the details will come later when we go through with our council.
So as you know, during COVID, when we expanded telehealth, it had significant positive impact, especially on mental health services, in terms of improving access. And
You didn't state your name for the record.
Daisy Rebecca, ranking member at House Health. So telehealth is incredibly important, especially for mental health services. And we also know that administrative burden of providers is crushing. And we had testimony that told us that patient notes and that burden is basically the biggest challenge that many mental health providers have in their work. However, when they are able to record telehealth appointments, it allows them to go back and accurately complete their notes so that they can be compliant with all of the reporting requirements they have, and also in managing their patient care plans. So it's an important thing for both addressing the provider burden, making sure that care plans are, we're maximizing the quality of care for patients, and that we're also maximizing client or patient providers' ability to tap into modern technologies. I think that's it in a nutshell. It's really that simple.
It is. No, be careful of saying it's simple.
Yeah, I know. I can know that.
But yes. Oh, understood. Okay, so it's just this little short bill.
It is.
Wow. Okay. So, question for you: currently, if you're going to the counselor's office, can they record in the office? Can you give consent there?
Yes.
So this is just that it allows for that telehealth recording.
Yeah, telehealth specifically.
Okay.
Yeah.
Okay. All right. Are there any conditions that are placed on the provider for that? Oh, maybe
Security.
doing it in a place where no one else can. We have telehealth protections, is what I'm asking already, that protects the patient's data and information.
Right. So HIPAA and all of that still applies in terms of confidentiality and data and the way that they store it. They still are bound by HIPAA, as well as client or provider responsibility that they
Yeah. Okay, thank you. And what was the vote on in your committee?
Give me one moment. Do you have a question?
Yeah, go ahead.
It's not really a question, Representative Rebecca, but it's more just a comment and a thank you. I'm the sponsor of the bill on this side, and it came to me from a school board colleague who's also a psychology professor at UVM, and he was very passionate about trying to make this happen. So just wanted to say thank you. for taking it up on the house, in the house and making it.
So
To me.
you amended it? Was there any amendment that you made?
1001 was the vote.
10-0?
That's right.
Thank you.
Um, I don't believe we amended it. I'm sorry, I don't,
You're Senator Gould,
I'd have to ask Jen, that's,
Jen.
yeah,
Yeah, we'll ask her.
or it would be Katie, right? Katie, this is,
We have Jen down for it.
okay,
Yeah, but it could be Katie. She may be here.
yeah. I would have to look.
That's okay. And
Sorry, this again, it was, January was quite a while ago.
It was 10 years ago. Right, thank goodness, right? Thank goodness. What about the floor vote? Was it a voice vote?
Yes.
Okay. Sounds good. Thank you.
Thank
It's a
you.
great bill. And
Thanks for taking it.
we'll see how quickly we can act on it. Who, is there any? Was there any pushback at all from any of the testimony that you took?
No,
So it was pretty positive.
Yeah.
We should hear from someone in here, I think.
yeah, there are people in the room here who testified.
Yeah.
For the game, so we're.
Perfect, thank you. Good work.
Thank you.
And Jen is on her way down. So what we're going to do is we're going to bring another representative up to go through H611. Representative Rebecca. This is a longer bill, but just really, as you get it, we're interested in the problem being solved and what the bill does. And I know you're going back a ways.
Yeah, so 611 is the annual housekeeping bill for the Department of Vermont Health Access, our Medicaid department. So every year they bring us basically a punch list of items that simply need cleaned up in statute. So that's what this bill is.
So it's more of a technical corrections, technical improvement type bill.
Correct.
Is there anything outstanding in the bill that you remember that we should?
Yes, the one thing that we did take some time to address was the date for the implementation of doulas.
Okay. So the doula date is in
The
here.
doula date is in here, and so there was some back and forth with the Medicaid policy department and the folks representing the doulas regarding whether how they could implement doula certification while also billing Medicaid and meeting Medicaid requirements,
Yeah.
which were either to have a physician referral or for the doulas to have some sort of training that sort of medicalized what they do. And they both agreed, the Medicaid office and the doula teams decided that they would allow, the doulas were fine with either, but we wrote in the bill, I believe, that they would have a referral process. So a birthing person that wants to have a doula would have a referral from their general or physician so that the doula could then bill Medicaid.
Oh, okay, I got it.
Yeah.
Okay. We've heard from, and we'll hear again, I mean, we heard from the medical community, OBGYN folks, that doulas were important to the care of their patients. So there will be folks, there will be MDs or others out there who would make that referral. So we go here and here.
Yeah, this is reflective on what you've said. I just get nervous. We continue to put more and more onto Medicaid. Because I think Medicaid's gonna change. The 1115 waiver, I just get nervous about doing stuff like that. Maybe I'm the only one, but at some point, I think Medicaid's gonna change really drastically. And so then those services are gonna be covered by what, GF? No. Well,
General fund doesn't have any money.
well, that's what I'm trying, that's
Yeah.
kind of what I'm trying to say, so that's the only thing that I get a little bit confused.
So we'll have Diva come in and talk about that. When we took testimony last session on this, it was a fairly minimal amount. I understand, a number of straws have their effect. But this one is one that we've been through this one.
Okay, I did know.
But that's okay. No, your comment is a very relevant and important. Good. Senator Gould.
I was just wondering, does the referral, thank you, Chair, does the referral specify what kind of medical practitioner would write the referral? Is it like a primary care physician or?
And Jen's here.
Sorry.
No,
Get in the weeds, yeah.
no, I believe we did specify who the referral is coming from.
Good, thank you. All right. Anything else we should know? What was out of committee, if you remember that one?
It was unanimous. I believe it was 11-0-0.
Okay, and then the floor, was that similarly,
Voice vote.
okay? That's always helpful.
Thank you so much.
Thank you. Good work.
Thanks.
Good morning. Good morning. So we've had Representative Rebecca give us the overview of both H84 and 611. So maybe we can walk through the bill a little bit.
Which ones do you want? Which one do you want to start with?
The 84, that's the long one. So
Yes.
Jen. I think she's ever heard for Joe.
I think she has, actually, so I tell her. Sure.
In and out. The stump. Okay, no, we're gonna go over the bills. Now. From there.
I think Jen's focused on other stuff.
Is there good at saying it's tomorrow? Okay, I just sent you a new one because I saw you were in, it says maybe scheduled for tomorrow, but it's on my calendar. Okay. Yes. So we are looking at H84. All right. Good morning, Diane Harvey, Office of Legislative Counsel. So this is H84, an act relating to allowing telehealth appointments to be recorded with patient and provider consent. And so this bill is pretty straightforward, pretty short. Under existing law that sets out the parameters for healthcare services delivered through telemedicine or and audio only telephone, there's a specific provision saying that neither a healthcare provider nor a patient shall create or cause to be created a recording of the consultation with the patient. And this would add in both cases unless both the patient and the provider consent to the recording. It would take effect on passage. All there is to it. I'm happy to tell you more about anything.
And that's both for audio only and for video.
Right. So telemedicine is the live interactive audio video like Zoom, which is much harder to explain before everybody started using Zoom. And audio only telephone is what it sounds like. Just telephone.
So the work that we've done on telehealth and telemedicine previously, this just falls into that chapter and that sort of the protection that's around it.
Exactly. We have provisions in two different titles around telehealth. One of them is in Title 8 around insurance coverage, and the other is in Title 18 around the actual delivery of healthcare services by telehealth. Telehealth is sort of the umbrella under which telemedicine, audio-only telephone, and other forms of telecommunication work for healthcare delivery are sort of the umbrella term. So yes, telehealth service delivery is in Title 18, and that is where these two provisions are.
Thank you, Caroline. So this already happens in face-to-face appointments, right? Between a doctor and a
It
patient.
can, there's no prohibition on it
Okay,
for in person.
okay. So in a way, this is just kind of, trying to align the two so that you can do it in person and you can do it on telephone.
Right. It would be treating the reporting the same, whether the patient was in person or the appointment was remote.
Thank you.
So storing forward means,
Store and forward is sort of different because it's not included in this. Store and forward is when, well, if you put it the other way first. Telemedicine is the live interactive.
Yeah.
Store and forward is asynchronous. It's not at the same time. So it might be an image or a scan or something of a patient that is then provided to another provider at a distant site to read, not in real time.
oh, thank you.
All right. Any other questions with that? Okay, so now I'm gonna ask a question for the folks who are in the room who have been involved with the bill previously. And let me know, are you ready to testify on this bill today? I'm looking at group. Okay. If you're ready to testify on the bill today, just raise your hand. One person, two people. Two people, all right. Well, what we'll do is we'll move along to H 611. We'll go through that bill and then we'll make a decision about how we deal with, we do need to take testimony, in particular on 611 from referred. And that we do need testimony on H84. I'm not thinking H84 will be extensive, so I want to make sure that we have the data to support any decision made. Okay. So.
Okay, moving on to 611. H 611 is an act relating to miscellaneous provisions affecting the Department of Vermont Health Access. Starts off with a section that is amending the statute requiring that currently requires health insurers and DIVA health insurers with more than 5,000 covered lives in Vermont to provide a list of prescription drugs for which the cost has significantly increased over the last couple of years in a short period of time. And the kind of vision when this was first enacted was that the payers, the insurers, and Medicaid would flag drugs that the cost has gone up for them a lot, and there's significant interest in understanding why. And then the Attorney General's, those would be provided to the Attorney General's office and posted. The Attorney General's office would reach out to the manufacturers and get information and report back to the legislature on what's going on. It has not rolled out, I think, as hoped. There have been significant difficulties, I know, from the Attorney General's office trying to get information from the manufacturers. And so you have a report that does get submitted to you every year, but I think it's largely the same things saying, there's a lot that goes into drug prices. So this bill would eliminate the requirement that the Department of Vermont Health Access create annual lists of its prescription drugs for which the prices have gone up significantly and provide them to the Attorney General's office. And my understanding, some of the rationale for that is also that drug pricing in Medicaid is just different because of federal laws that require manufacturers to give certain pricing to the Medicaid program. So
Because of federal.
to some extent, that
Why
this
they're-
one doesn't, why they're asking to be carved out. I do know just separately and something we'll want to probably take a look at. There's a bill that came out of the House I was not involved with, but it's the reports repeal bill. And that is taking some pieces, some different pieces out of this report requirement. And so I think we'll want to look at them sort of holistically and see what's left in the statute so you can decide if there are things you want to keep or if you want to get rid of the whole thing or if you want to change it to something else.
Where is that bill now?
I think it's in GovOps. You may see it.
Oh, so it's in the Senate.
Yes, it has come over at H907. I think I looked
H
at
nine oh
that.
seven, we'll write that one down.
Just something for us to be looking at. And what probably would make sense when we come back to this bill is that I can pull out this section of statute entirely and kind of show you what gets crossed out in the two different bills. And then we can look at what would be left, and what you want to do with this report. But for purposes of 611, it is just taking DIVA out. So it is striking the requirement, and just moving this definition of health insurer up here. Taking out the requirement that DIVA create annually a list of 10 prescription drugs that the state spends a lot of healthcare dollars on, and the wholesale acquisition cost has increased by 50% or more over the past 5 years, or 15% or more during the previous calendar year. At least one generic and one brand name, et cetera. And then there were two different lists that DIVA was creating. And yeah, this would get rid of the DIVA requirement, but not the health insurer requirement. So that is what section 1 does.
So the health insurer requirement is to,
Health insurers also have to provide a list of health insurers with more than 5,000 covered lives in this state for major medical insurance, which just gets moved up to the definition section.
and for the drugs that have gone up more than 15%.
Yep, more than 50% over 5 years or 15% over the previous calendar year.
Yeah.
And then the Attorney General's office is directed to look into that. Attorney General's office would identify from these various lists 15 drugs, particularly the ones that appear on multiple lists, and then require certain information from the manufacturer justifying the price increase. And I would encourage you to go from the Attorney General's office if you're interested in learning more about how this has rolled out, but you can also look at the reports that have come into the last several years on the legislative side.
So when DIVA is talking about this, that may be related to their PBM, you don't know.
I think so. I'm just looking at some of the language that they mentioned, that DIVA mentioned in part of its information.
We'll sort it out.
Okay, yeah, you don't want to hear from DIVA. I think part of what they said is the information supplied by DIVA is unhelpful because DIVA is federally prohibited from sharing drug-specific net cost information. So the information was not very specific.
So federal preemption is.
All right. Section 2 is making a change to a bill from or to language that was passed last year. Those of you who were at this table last year may remember that there was a significant amount of work done around the drugs that are provided through the 340B, federal 340B drug pricing program. And those are drugs that are available to outpatient drugs available to patients of hospitals and FQHCs and certain other federally identified covered entities that can participate. And many of them use a contract pharmacy. And there were some concerns about whether the manufacturers were refusing to provide the 340B drug pricing to the contract pharmacies, even though some of these facilities don't have their own in-house pharmacies. So you, legislature, did a bunch of work on that last year. We are currently in litigation on some of it. And this piece of it seems like it may be subject to certain ongoing efforts at the federal level that may preempt us. This is language that under current law prohibits the manufacturer, prohibits the manufacturer or agent from doing a rebate for the 340B covered entity or its contract pharmacy. So it says you have to do a discount at the time of sale and not, or time of purchase and not a rebate later on. and things have been, there's some shifting federal landscape, but it does seem like this may not be a state level decision. And so this is proposing to take that language out of the statute. Section 3 makes some changes to the membership of the Medicaid and Exchange Advisory Committee. And this would require that so we are required by federal law to have both the Medicaid and an Exchange Advisory Committee. I believe Vermont combines them into one. Makes for a large committee of at least 22 members, because there are lots of different groups. But a new federal law also requires that our advisory committee include individuals who are also members of the Beneficiary Advisory Committee, which is another federally required committee. So it would require the required overlap. It takes out language allowing the commissioner to reappoint members to serve more than one term, but does not prohibit members from being appointed to serve more than one term. And again, most of this bill was requests from the Department of Vermont Health Access, so you will want to hear from them on their rationale. For these, in the existing law, the commissioner of DVA appoints certain members. One representative of health insurers licensed to do business in the state, the commissioner of health serves, and then at least 1/4 of the remaining members have to come from certain constituencies. And this is mostly a language change. So under current law, it says individuals, self-employed individuals, health insurance brokers and agents, and representatives of businesses eligible for or enrolled in the exchange. This would change that to make representatives of those eligible for or enrolled in qualified health plans, such as individuals, self-employed individuals, health insurance brokers and agents, and small business owners and employees. So representatives kind of modifying all of those, although it could be the individuals themselves. Section 4 makes
Just so 1/4 of the membership would be resulting would be.
It's still
five people.
at
Is
least.
that right?
Yes.
2 that are already there.
Yes, it's the committee must be at least 22 members.
Yes.
So yes, so
So it
it
could be more. So they have a choice. Okay, all right.
Section 4 makes a change to the reflective health plan benefit plans statute. This is a statute that was created with, I think it's maybe more than a few years ago, but a handful of years ago, when there were reductions to federal or discontinuation of federal cost sharing reduction payments to insurers. So the federal government, I think in the first Trump administration, was rolling back some of the assistance to consumers in purchasing exchange plans, qualified health benefit plans. And so Vermont created reflective plans as well, so that we could load up the premiums for the silver plans in the exchange with the cost sharing reductions to drive down more federal assistance instead of having the missing cost sharing reductions. So the whole point of the reflective health benefit plans was to provide alternatives to individuals. It doesn't affect the small employees of small employers. And so this is striking the language about employees of small employers. So this is still allowing the reflective health benefit plans for people who wouldn't be eligible for premium assistance, but only for individuals. Because there's no reason to do it for small. Section 5 is the Clinical Utilization Review Board. This is an existing board. Some of the changes here are just cleanup changes that I did. We don't need to say not later than June 15, 2010, because that has well passed at this point. But there is an ongoing requirement for DVA to have a Clinical Utilization Review Board, and they had asked for a bit more flexibility in what the membership looks like. So now, instead of comprising specifically 10 members, it would be a minimum of 10 members. We're correcting the name of the title of the Chief Medical Officer of DVA. It doesn't require, but allows board terms to be staggered, and doesn't specify the length of the staggering. And it requires, still requires the board to meet at least quarterly and takes out the outdated language around the first 6 months after its formation.
So, yeah,
So these are pretty, I think in this one, pretty minimal changes, but again, pretty happy to tell you why they want it.
This is for Jen. Has this board been successful? Has it brought good recommendations? Is it worthwhile? Is it, I have no.
Yeah, I think you'll want to, know their most recent report, I believe, was fairly recently submitted and attached to, or is posted on the legislative website. They do have a requirement for an annual report. I think my recollection is that Diva's testimony was that they are helpful. And these are providers who are advising Diva on, emerging trends in, services they might want to consider covering. Things from a clinician point of view to advise the commissioner who may not be,
Thank you.
may not have that knowledge for us. All right, section 6 is a change in bee farm eligibility. And this is again, I think, a fairly minor change in this case because it has never been calculated this way. So under existing law, an individual is eligible for assistance under bee farm. If the individual lives in Vermont when they apply, they're at least 65 years of age, or an individual with disabilities and has a household income not greater than 225% of the federal poverty level. Existing law says when calculated using modified adjusted gross income. It's my understanding that that has never been the basis on which they have calculated income for bee farm eligibility. And so this is a conforming change that was requested by the Office of the Healthcare Advocate. Section 7 is an increase to prepaid burial arrangements for Medicaid eligibility purposes. So this is, before we actually look at the language, this is an increase in the amount that somebody who is applying for Medicaid can have in their own prepaid burial arrangement that they have at the funeral home. And so an increase in how much they can have already put into that prepaid account and still be eligible for Medicaid.
Yeah.
So it requires federal approval. So this says subject to approval from CMS, the Agency of Human Services shall amend its rules and procedures, allowing Medicaid applicants and recipients to preserve monies, so set aside, keep those monies for funeral and burial expenses to increase from $10,000 to $15,000, the limit on the amount that can be preserved through an irrevocable prepaid funeral arrangement. And then there's certain requirements. So the written contract for the arrangement, which is these arrangements themselves are regulated in Title 26 in the funeral directors chapter. But as long as the written contract for the arrangement includes a provision specifying that Vermont Medicaid will receive all amounts remaining after payment of the deceased individual's expenses up to an amount equal to the total Medicaid amount paid on behalf of the deceased individual. And in the event that the person responsible for making the funeral arrangements for the deceased person fails to have funeral services provided, then after the funeral director gets to keep their piece of it as allowed under law, Vermont Medicaid would get all amounts remaining up to an amount, the total amount of Medicaid spending on behalf of the deceased individual. So that recouping is part of the Medicaid long-term care estate recovery provisions that exist in current law. So again, the whole impact of this is to allow somebody to I think perhaps in recognition of just increased costs of funeral and burial expenses, to keep more money in an irrevocable prepaid funeral account and still be eligible or keep their eligibility for Medicaid, but Medicaid gets to recover amounts in that account in excess of what is spent on the funeral, if there is anything, or if the funeral doesn't happen, but Medicaid doesn't get to scoop more than it was actually spent on the person's Medicaid care. Just a question for you.
Is there any limitation on burial? Could it be cremated? No.
We'd have to look at what is in the irrevocable prepaid funeral
Yeah.
arrangement statutes.
I think I did both.
Well, no. Yeah.
Yeah, I
No, don't.
Yeah, we have to look.
Yeah.
Did you have the? And then this says, subject to approval from CMS, the agency's amended rules and procedures would apply to prepaid funeral arrangements entered into on or after July 1st, 2027. Section,
Go ahead. Your question made me think of something else. There are more and more ways of being buried, cremated, and like natural burials. And I'm just curious if all of that is covered under this provision, and also why they upped it. Had it not been increased in a while? Is that?
I don't.
Okay.
Well, we got, yeah,
All right, sorry.
we got lots of questions.
You're not a Medicaid, you don't.
It
want
is it is currently in the
Right in
Medicaid
my
code, so that's it's not in statute.
to keep writing your questions down. I'm just doing it as we go through.
We're almost done. So sections 8 and 9 would delay for 1 year from July 1st, 2026 to July 1st, 2027. The date by which DIVA has to seek a state plan amendment from CMS to allow Vermont's Medicaid program to provide coverage for doula services. And so that's making changes in 2 acts from last year that were requiring Medicaid coverage for doula services subject to CMS approval of a state plan amendment, and DIVA would like longer to seek that state plan amendment given certain issues at the federal level.
So that's an 1115 waiver.
No, that is state plan amendment.
Different.
Yep, that is our state plan. And so we have a Medicaid state plan that spells out kind of how we administer a lot of covered services and benefits in Medicaid. Every state has a state plan, and we would be looking to amend our state plan. Our 1115 waiver is a arrangement with the federal government for and how we pay for services in the Medicaid program. Not every state has an 1115 waiver. They don't have to, whereas every state does have to have a Medicaid state.
I asked.
Yeah, I think I got confused there. Jen, so as I recall, federal government or CMS approves so many types of services under Medicaid. And then the state of Vermont, if they want to, can add to that.
Right, there's required and optional services, right?
Is this a required or optional?
So I believe this would be in the optional category to the extent it's addressed at all in the list of Medicaid.
So this could be another add.
This would be, yes, this would be an added service in our Medicaid state plan. So not so much about how we pay, but what we pay for.
Yeah, thank you.
Do you know what the timeline is for the state plan amendment? It says whichever one's later. Either July 1st, 27 or the approval of the state plan amendment.
Well, this is delaying the date by which they have to seek the state plan amendment. Because DIVA wanted more flexibility. But it can't start before we get the state plan.
Right, and do we have a sense of when that might be?
That is a DIVA question.
Okay, sorry, yeah, it's okay.
And then finally, the act would take effect on July 1st of this year.
Okay, so we've got a lot of questions running through the entire bill. We can ask. So this is also equivalent with S-162. I think I introduced it.
I believe so, yes.
DIVA, yeah.
Yes.
So it's DIVA,
Bill
part
is
of the housekeeping bill from DIVA.
Yes, exactly. Stephen housekeeping bill. Exactly right. And that, yes, same bills, I believe, identical bills were introduced in the House and the Senate. And then the changes were made in the House. And I will say, I believe that the bill as introduced, and maybe this may have been a difference between the House and Senate after I've said they're identical, but I believe the bill as introduced in the House for DIVA delayed the state plan amendment deadline and the effectiveness of the Medicaid coverage for doulas until 2028. And House Healthcare changed that to 2027.
We've been talking about doulas for a long time.
You have, I think half folks in the room would be interested in having your.
No. Okay, questions for Jen on the bill. So we have two bills here that seems like we can take them up and put some, testimony together for each of them. Eva is going to be really significant, but then there'll be others who have an interest in, each of the sections. So we'll make sure we get folks in for that. So if you're interested in H 611 for testimony, please let Melissa know. And we'll try to make that happen sooner than later. And then saying similarly with H 84, we'll get people signed up for testimony. We won't try to do it today. It doesn't make sense. But we'll have, if you're interested in testifying on H 84 on the telemedicine bill, recording purposes, then let Melissa know and we'll get it set up. Or there are a lot of bills that we have coming in. Some are going to be more challenging than others. So these don't feel as challenging. They are not, they don't lack complexity, but they don't feel as challenging as maybe some of the other ones that we'll be seeing. We'll do that. We have nothing for you. And we're scheduling this week a little bit later deliberately because we've been through the mill in this one and done a lot of work, and I respect the time that my committee has put into an effort and put into all the bills that we've worked on before crossover. So we deserve a little hiatus in that process. I don't know whether Katie is available to be down for a few minutes. I know where she is. Pardon?
Can I run upstairs real quick?
In a minute. I'm gonna give you a minute to do that. So what we're going to do is, we're gonna take a short break. We'll be back no later than 7 after, 10 after, but please 10 after, and then we'll take another look at the cannabis bill together. We're gonna get the reporter of the bill and talk about it. And then talk just to make sure we're not missing something important in there. And if we can get Katie down, even if she doesn't come down, I do have a proposed amendment for S-193. Remember, that's the forensic facility bill. And so, tell you a story about that. Because we do not have the bill in committee, we can't put a committee amendment out. So I have an amendment that my name is on, but you all have contributed to. So we'll look at that proposed amendment. I've worked with Katie on it, worked with Karen Barber and others at DMH, and talked with Senator Harrison about it, who's doing institutions. She's agreed to sign on to the proposed amendment that I will put out in front of you. And then you can decide if you want to sign on to it or not. And we'll try to move it along. If we can get Katie in here, that would be really cool. That's it.